Hello, everyone. My name is Roomasa Channa. I'm an assistant professor in the Department of Ophthalmology and Visual Sciences at the University of Wisconsin in Madison. I'm a clinician scientist, which means that I split my time between seeing patients in the clinic, doing surgeries, and conducting research. And this combination of clinical and surgical work, as well as research work, keeps my research focused on addressing issues affecting our patients. My area of specialization within ophthalmology is retina, which means that in my clinical work, I take care of patients with retinal diseases. The retina is the inner lining of the back wall of the eye. It's like the film of a camera. It processes visual stimuli from our surroundings before they're transferred to the brain. A major retinal disease that is a leading cause of vision loss among working aged adults in the US is diabetic retinopathy. My research focuses on preventing vision loss from diabetic retinopathy and identifying new pathways of vision loss among patients with diabetes. Diabetes is a major public health problem. The global prevalence of diabetes has more than quadrupled over the last 4 decades. An estimated 34 million Americans currently have diabetes, and about 1 in 3 have prediabetes. Individuals with diabetes are at risk of vision loss from diabetic retinopathy, which is a complication of diabetes that affects the retina. The national prevalence of diabetic retinopathy is estimated to almost double from 7.6 million in 2010 to 14.6 million in 2050. And diabetic retinopathy is estimated to cost the US approximately $500 million annually. Alarmingly, diabetes and its associated blinding complication of diabetic retinopathy is not only projected to increase among adults, but also in youth as the prevalence of type 2 diabetes increases among American children. A large multicenter study of patients with onset of type 2 diabetes in childhood showed that over half developed diabetic retinopathy during the course of follow-up. Over the past few decades, there have been effective treatments developed for diabetic retinopathy, such as laser and injections, and timely treatment can prevent progression to vision loss. My research program focuses on two problems that continue to make diabetic retinopathy a leading cause of vision loss. One is poor compliance with screening eye exams, and two, identifying novel pathways of vision loss amongst patients who lose vision despite standard of care treatments. It has been shown that screening for diabetic retinopathy and early identification of disease can prevent irreversible vision loss. My group is working on addressing barriers related to poor compliance with diabetic eye exams by studying the implementation of point of care artificial intelligence based techniques to screen for diabetic retinopathy. The advantage of point of care screening is that patients with diabetes do not need to make a separate visit to the eye clinic unless they need an intervention. By making screening more accessible, for example, at their primary care doctor's office, and providing immediate screening results via AI-based evaluation of images can significantly improve the number of people who get screened and diagnosed in a timely fashion. Our recent study showed that implementation of AI-based detection of DR, diabetic retinopathy, improved compliance with screening exams from 46% to over 90%, particularly among minority youth with poor access to care. We're continuing to expand on this work by conducting a randomized clinical trial comparing artificial intelligence-based diabetic retinopathy point-of-care exams with in-office diabetic retinopathy screening eye exams and studying the impact of AI-based diagnoses in addressing disparities in access to care, cost effectiveness of implementing artificial intelligence-based screening, and to evaluate how artificial intelligence can impact continued follow-up with long-term treatment and long-term outcomes. The second aspect that my research group focuses on are the people for whom we need novel treatments. These are the people who lose vision despite the current standard of care treatments. For these patients, it is important that we identify novel pathways of vision loss. My group focuses on doing this by leveraging advances in retinal imaging, big data, and AI-based tools to analyze these data. Big data and the tools available to analyze it are changing the way we learn about diseases. The amount of global healthcare data has increased dramatically. In 2013, healthcare generated about 153 exabytes of data. For reference, 1 exabyte is equal to 1 billion gigabytes. In 2020, this had increased to over 2,000 exabytes. These data are changing the way we learn about diseases. Special computing sources are needed to store these data, and special techniques involving artificial intelligence and machine learning are needed to analyze these data and leverage them to improve our understanding of diseases. My team is working on establishing and leveraging large retinal imaging and genetic data sets to identify genetic factors associated with diabetic retinopathy. In order to analyze data from large retinal imaging data sets, we need automated image analysis techniques such as AI-based tools that can extract data in an automated fashion, and they can also identify features that may not be readily visible to the human eye. These image-based biomarkers or endophenotypes can potentially provide a more detailed description of a patient's disease state. Our team's goal is to correlate these image-based biomarkers or endophenotypes with genetic data to identify novel disease pathways and provide more individualized treatments that can ultimately lead to more effective treatments and prevention of vision loss from diabetes.